Hi, everyone, and welcome to OT Echo. My name is Kate Barlow. I am chairing today's meeting, and I am so excited. Today we have Ania Leone, who is going to be talking to us about spinal cord injury and OT's role. If you would remain on mute while she is speaking, we would greatly appreciate it, and then she will take any questions after she's done presenting. And then we will have a case study and we will move into breakout rooms where we would greatly appreciate it if you could put your camera on to participate in the breakout room. So without further ado, Ania, welcome and thank you so much for coming. Oop, you're on mute.
I am so sorry, guys. Hi, everyone. Thank you so much, Kate, for introductions. I'm Ania Leone. I'm practicing clinician like most of us out of Duke currently in North Carolina. And I would love to talk to you today about spinal cord injury and our role in care for these patients. It's a very hefty topic, so forgive me that there are so many slides. I'm just not the best person to present this topic concisely, I suppose. So we will breeze through a lot of slides so that you can sort of take a look at that on your own, and I'll focus on more important parts that I feel that we will need for our breakout sessions. So let's see if I can get this to work here. Sorry. Okay. So you may have taken a peek already at our learning objectives. We're hoping to understand better how the level of injury is impacting our independence and our role as OT in caring for that particular patient. We're going to review some basic ADL tactics with look for compensatory strategies, looking at some equipment and any kind of interventions that we would focus on where it comes to caring for patients with spinal cord injury. And lastly, we will hope that after seeing this workshop, you'll be able to understand a bit more about OT's role in caring for this particular population. There's just a few statistics that I'll go through. I'm not going to spend too much time here. Level of injuries. I've even included, how costly it is for us in the US anyway. I know you guys are joining from all over, but in the US, it's quite costly to care for these patients. Insurance may pick up a good portion of this stuff, but there's just a huge indication of how much are we able to do for these guys as OTs, as therapists in general, to prevent a lot of those secondary injuries and issues that they will inquire over the time of dealing with the injury. Next is the syndrome. So there are several different syndromes where it comes to SCI. They sort of dictate the level of severity. Again, that's something that it's very much pathophysiologically oriented here. I'm not going to spend a lot of time, but I thought that this picture depicted well what part of the cord is affected and what it means in terms of level of injury or function from motor and sensory aspect. So it's just a good picture for reference here. Speaking of additionally, then we will move over to ASIA examination. So ASIA, American Spinal Cord Injury Association, is sort of the standard for all practitioners to use when we are assessing a patient with spinal cord injury. And in it, you will find that we are looking to test sensory and motor levels in order to develop or determine what is the neurological level of injury, which is really what we're going to be working with. We do want to determine whether there is sacral sparing or zone of partial preservation in complete injuries, but that's sort of like your Bible, your guide as to how to initially accurately assess an individual with spinal cord injury. There are 28 key dermatomes. It's really important to test light touch and pinprick. The most common mistake made by practitioners is to ask a patient, you're testing the specific dermatome and you're asking them, can you feel it? And they say yes. They may feel pressure, that there's some deep pressure that they may be perceiving. However, in order for this to be either absent or impaired, they need to actually tell you the difference between light touch and pinprick. So it can just be yes or no answer whether I feel it or not. And there is this scale on the slide that you're going by. It's either absent, impaired, or normal, or not tested. You may have a reason for which you cannot test, whether there is skin integrity issues or any other reason where you wouldn't test that particular area. Like I mentioned, you're going to use something, just a light touch cotton tip applicator. The common mistake here that I've seen in practice being done is that we are sort of swabbing patient, for miles, it seems, on their skin. It really should not exceed a 1 centimeter or about half a inch in diameter in terms of how much skin area you're covering when you're testing that light touch. Similarly for pinprick testing. And if the patient is unable to differentiate, you're going to document that as absent sensation and not impaired. S4, the dermatome S4 and 5 are just incredibly important in spinal cord injury because that's really the only level that we would focus on in determining whether the injury is complete or incomplete, which some of you may know that it really drives our treatment focus largely. And the only way to test it is in that area, which is going to be in a perianal area, our most caudal aspect of the spinal cord. And a lot of times you will see that testing done by your physicians, but from lots of workshops that I've attended over the years, it appears that OTs actually are taking this as a role. Maybe it's not the most glorified part of our practice. However, that anal exam is so important to be able to determine that whether there is really sensation or even perception or deep pressure in the anal area. That sort of drives the conclusion whether injury is complete versus incomplete. And we do test both pinprick and light touch in that area as well as that final digital rectal exam to finally confirm whether it's present or absent in terms of that pressure. So there are key motor groups to motor examination when it comes to ASIA scale. I'm not going to go through, your 6-point scale, obviously, from muscle twitch to full activation to normal strength. I've listed here both of the 10 key muscle groups for lower and upper extremity, but obviously we'll focus on upper extremity. And while there are so many muscles between C5 and T1 that are very important in that function, we as OTs and as practitioners who are following the ASIA scale to examine the patient, we really are going to focus on those 5 up on the top. So we are honing in on our elbow flexors, wrist extensors, elbow and finger extensors, flexors, as well as abductors. We'll move on into a little bit more in depth into the following. Let's skip through this. This is just a little further talking about no sacral sparing and level of injury, but for the sake of time, I'd like to move forward to the muscle testing. Just so you know, on this slide, AIS, which if it's confusing, it's level of impairment. So we're going through from complete to motor incomplete. We're going from ASIA A to ASIA E, A being obviously the most tragic outcome where that level of injury has been complete. There is no motor or sensory function at all at or below level of injury, all the way to ASIA E where everything is returning to normal, hopefully by the end of our treatment. Here is just a little schematic as to how you would determine, whether it's complete or not and which direction you will go. And why is it important? We do like to have a general prognostic idea as to which direction are we going to go with our patient. What are we going to focus on early on in our interventions? And that will really be important to know whether injury is complete or incomplete. Are we going to focus on compensatory strategies versus recovering as much function as possible based on current level of function? So it would be important. I won't go through the actual schematic, but you can kind of use it as a guide to help you determine whether the injury is complete or incomplete. that's just the official, I included here, official sheet that you can use when you are doing your testing for motor and sensation. You just, it's obviously tedious. It's a long assessment. It doesn't always happen in one session, depending on the setting that you are receiving this patient in. In acute care setting where I'm currently practicing, it's almost impossible to do this because we just don't have enough time. Versus when I was in inpatient rehab, that's something that we would focus on. We would take 3 days at times to continue that evaluation to really have an accurate idea what level is most representing to this patient. That's also helpful to them, to their families. They want to know, anything there is to know about their injury once they're able to accept the ramifications of what's happening to their body. So it helps us and them to sort of show this is where we're looking at and why we're looking at those particular areas. That's just, as you can see, I like schematics. I like to give you picture representations of what each level, each muscle represents, which spinal cord level is represented and what's it responsible for. And those are, again, just one of the key muscle areas as far as neuroinvolvement. And then we'll talk quickly about phases of spinal cord injury. The acute phase, obviously, is from the initial injury. It can last anywhere to 12 months. It sort of blends into subacute phase a lot of times with these guys because we're talking about spinal shock initially, which could be anywhere from 24 hours to 3-4 days. And then they are depending whether there are any involvements of surgical interventions, how long are they spending in acute care before moving on to inpatient rehab. So there are some variations in terms of how long that phase lasts. Obviously, we're going to focus on preventing any complications in those acute phases. Maximizing function to the best of our capacity at the moment, depending on the setting, depending whether the patient did have opportunity to go to inpatient rehab versus just go home. So many factors get into a way. Insurance is one of them, or even general global localization, right? Your location where you are and where your access to this type of rehabilitation. And naturally, in a chronic phase, which can take anywhere in a year 2 to 3, the natural course of recovery has likely plateaued. We will then focus, if that's where you are picking up your patient. A lot of times, this is the first time this patient will have any kind of access to therapy. So if that's where you're picking up the patient, your focus will be different. We're largely going to concentrate on compensatory techniques and assistive devices, approaches, this is where we become, a patient called me once, and MacGyver. We become these MacGyvers because we are trying to make any kind of adaptation, sometimes out of nothing, to make some level, some form of function for this person possible again. And we're hoping that we will take part and be facilitators in establishing some sort of optimal conditions for the long-term maintenance of the current level of functions of where they are. And this is just a little scare tactic, I guess. I decided, I work in acute care at the moment. So a lot of times this is what my patient looks like when I receive them. They're in ICU likely. They have tubes and lines coming out of, every surface. It can be overwhelming. It can be, I know for a lot of our students, our new therapists who have not dealt with spinal cord injury patients, this part is overwhelming and you sort of don't know where to start. And of course, like with everything else, back to basics, our assessment, where we just sort of take it in and then break it into components. Back to our assessments. We are looking, just like with any other patient, for a lot of the key areas will be similar in terms of our assessment areas. We obviously are going to look for the motor and sensory function that I mentioned already. Bowel and bladder function will be huge with this population. We will have several slides towards the end just to sort of touch on it. This is such a huge topic in itself that it's hard to condense that in a 30-minute conversation. But I wanted to at least have some key components for you guys to think about, if not dive deeper at some other point at your opportunities. We're looking at the functional mobility as always from the get-go. We want to know what's the best they can do. Standing and ambulation comes into play sometimes, depending on the levels, and our PT friends are going to be much more acutely honing in onto that. Our self-care, of course, IADLs and work of leisure. We're again looking at that whole patient as we always have in our profession. Here I just included several different assessment tools that, by the way, are included at the last slide. There are some resources that you can fall onto, and these are from rehabmeasures.org. A lot of these assessments are, if not most of them, are free and reprintable, so that it's easy to use in any practice area that you may find yourself. As you can see, the ASIA scale is kind of the number one because it's such a go-to when you are assessing your SCI patient. I often use the COPEM, the Canadian Occupational Performance Measure, because I do want to know about all the other aspects of the patients, what's important to them. FIM score, with the functional independence measure, that's sort of very specific to inpatient rehab. We don't necessarily have time for that in acute care, but inpatient rehab, that is their holy grail. And there are a few others that you can take a look at your leisure. As far as early therapy intervention, hopefully we're getting this patient shortly after initial injury. We're looking at those functional deficits. We'll do goal setting like with any other population and their family members. Neuromuscular intervention will start immediately. And then again, that depends what you are able to do. Sometimes that means just working on range of motion, educating family on safe range of motion techniques, because that's going to be so important, that joint protection techniques from the early aspect of treatment. And then moving on, if you have access to some electrical stim, fantastic. It's not, there was a study that came out, I think in 2017, they were measuring what was the most effective approach to treatment in terms of spinal cord injury patients. And it seemed that it was just really our OT skill, our hands-on practice seemed to have been the most impactful. FES, functional electrical stimulation, had a lot of some validity, actually, not a lot, but there is some that's still growing. But our immediate skill, our manipulation of patients' joint and muscles, those were the things, our approaches that of adaptation, really those seem to be the most effective thus far. Just to point out, if you have opportunity to consult your speech language pathologist, certainly those are a lot of times, depending on the level, higher level tetraplegia patients will have a lot of speech therapy needs. And if you have opportunity, if you have them available in your facility, this is the perfect time to have them come in and a lot of times collaborate with you if possible. What's important, I think, to also bring up with the spinal cord injury patients, a lot of times hand in hand with this diagnosis goes brain injury, right? Traumatic brain injury, because depending how they sustain spinal cord injury, brain injury is often involved. So speech therapy is also another resource for you to collaborate with on those cognitive approaches. Okay, moving on. Our role, which is kind of what we try to get into in this topic. As always, we sort of are the gurus of task analysis and performance, right? We are problem solving. We are great at adapting and just modifying, grading activity for the patient. So not surprisingly, our role is recognized in a way that we're able to facilitate progress and recovery with this population. Adaptive equipment is something that, if we're fortunate enough to have, can make a huge impact on function with this particular population, especially if there is some upper extremity preserved. How does the level of injury impact the level of independence, right? It will largely, it's so closely correlated, which is why we want to know early on what level our patient is functioning at. And so here we have those key muscle groups that I mentioned several slides ago. At C4, we are anticipating that our patient will have some neck accessory muscles and diaphragm trapezius. You may have heard from school, you need C3, 4, and 5 to stay alive. So that's usually are going to be at that level, we can anticipate that this patient is going to likely breathe on their own. They will be able to get off the ventilator. But besides that, they will likely need total care, if not maximal, in terms of ADLs, IADLs, and any participation in daily routines. C5 is incredibly exciting because that's when we have those deltoids and biceps already, right? The key muscles, biceps, we mentioned, that's one of our key areas in assessing. If we have biceps, we're now opening the world towards feeding, grooming. So C5 is an exciting level for OT practitioners who work in spinal cord injury, because we can now put our skills to test and we can show that this patient can still have independence with a lot of, not all of their self-care, but a lot of components are not coming into play where they can have independence and control over their treatment. Moving on to C6, which is incredibly, what do we gain in C6 is those wrist extensors, right? That's the key muscle group here. So we're talking about tenodesis grasp versus, having an arm hanging. They are now able to move their wrist into extension, which is promoting tenodesis grasp. We are now able to use less adaptive equipment for some kind of grasp, so that they're able to manipulate their skin. They're able to manipulate dressing, different. It's sort of opening up their world to greater independence. There is the potential at C6 for maybe even self-cathing. I've had some patients who have successfully been able to self-catheterize using the strength of their wrists. So that is a huge level to achieve, to be able to have muscle groups innervated at that level. Moving on to C7, C8, that's where we celebrate those triceps. That is incredible for our transfers, right? At triceps, you have elbow extension. And so with that comes stability with sitting, because now they're able to lock out their elbows while seated at your bed or on the mat. So that becomes a huge plus in their functional status again. And lastly, C8 to T1, they gain that pronator, and all flexors and extensors of the hand and wrist are coming into play. So we're talking more about normal hand use, which sort of leads into eventual independence with most, if not all, ADLs. So those are our key muscle groups that we are looking for in a spinal cord injury patient. Here is just a good grid that will you can fall back on when we talk about tests later, just what kind of level of assistance we would anticipate when we are looking at specific level of injury. And we can go back to that later. We won't spend time. As far as eating and your patient with C5 level of injury, so remember at C5, there is no wrist extension yet, right? But we have biceps, so we really need to stabilize the wrist for any kind of functional grasp to happen. It's going to be largely splinted. So splinting for ability to put a utensil in, splinting for ability to be able to self-feed or perform grooming tasks. The picture that you're seeing here is not exactly the type that I'm using. We're using wrist cock-up splits at the moment, which is sort of a prefab, very similar idea to it. There is a little pocket. If you look at the space right above the CMC joint, there is a pocket where you would insert a spoon, fork, any utensil you're using, or toothbrush for shaver, so that this patient is able to bring that hand to mouth and manipulate the utensils to be able to engage in those ADLs, in those feeding or grooming tasks. There's also an example of plate guard, which I'm sure you have seen, but that's just so that they have some sort of a bumper, right? They don't really have control, but if they have a bumper to swipe against, they're able to self-feed even at the level of C5. With C6, since we've mentioned we do have that wrist extensor, we can be a bit more of a minimalist at this, right? It's what you're seeing on the picture, right upper corner. It's a universal cuff. So it's just a simple strap that's Velcro over the hand, and then they can use a utensil. If you don't have that available in your clinic, in the setting that you're in, you really are able to find a piece of fabric, any kind of fabric, tape potentially. This is, again, when you become this MacGyver, and you can easily fashion something like this that will still serve as a U-cuff that we call, that's a tool that's able to support a utensil. You could also make additional larger sort of like a bolster, some kind of roll where they could potentially hold a spoon with, if you found a way to fashion that spoon to the material. So it doesn't need to be a prefabricated thing that some of us have privilege of having in our clinics and others don't. We still have opportunity to use our creative skills to create that kind of adaptation. The lower picture is just showing that tenodesis grasp, right? So they're able to manipulate some things, depending on a strength that takes months sometimes to develop. So those early phases are not going to be the prettiest, but it's something that they're working on. I've listed other forms of adaptations that are not pictured, such as rocker knife or adapted cutting boards. Again, it's something to increase that independence. However, it can be adapted with other, daily household items that you can find around, and hopefully make that slightly easier for your patient. Just this is C7, so they are having that wrist extensors are strong. They're able to hold things easily. So that's just something. There's still no finger flexors or extensors, right? So there's no true grasp, but now just something, a little hinge to put their hand in to be able to hold and bring things to mouth. So just a few examples of what can be done with this level of injury. Other considerations when it comes to spinal cord injury. Autonomic dysreflexia is huge, unfortunately, with this population. So it's important to be aware of it and screen for it, because it can happen sort of out of the blue. Your patient can feel fine, you're going along your session, but all of a sudden you may see some of these symptoms that might be, related to other things under different circumstances. But if this is an individual with spinal cord injury, you are really, in the back of your head, there's always that autonomic dysreflexia question, whether this is it, because it could be a life-threatening situation. And it really is an sudden increase in systolic blood pressure, generally rises from 20 to 40 mm's or higher at times, but you want to pay attention to that. You want to really pay attention to sometimes you're not going to see all these symptoms. Sometimes all you may notice is just the goosebumps that were in there 2 seconds ago. So you really want to be paying close attention to your patient at all times. And this really usually typically happens as a response to some kind of noxious stimuli, which it could be as simple as they're in increased pain, their bowel and bladder need to be emptied. Maybe later, if it's later in their phases, maybe it's sexual activity, maybe it's polycatheter, overstimulation. Really, so many different factors play into role here. So just honing in on our observation skills, as always, right? So important with this particular situation. Okay, concentrating on aggressive pulmonary care is very important for these guys, particularly higher level tetraplegias, right? The C5, C4s, where the pulmonary function may not be as strong. Secretion control with suctioning in those early stages, when they're in acute care, particularly if vent support is still in place. Consistent and thorough oral care, which is one more reason to help them become as independent as possible with that basic grooming task as oral care, because they can then be more they don't have to rely on a caregiver to do that for them. And it's so important in pulmonary care. Paying close attention to the trach, if that's still part of the equation with your patient. Always elevate their head of the bed. You don't want to leave this type of patient lying flat in the bed. And again, collaborate with your coworkers if you have that opportunity. RTs and speech therapists are great in this area. We always want to look for those DVTs, and this population is in particular risk, especially if they don't have sensory function, right? They can really tell that there is pain in the leg, or the area is hot to touch. So it's important to really pay attention to that. Some of the approaches you go into, if you're in a hospital clinic setting, you go into use the sequential compressive devices, SCDs, or just sort of these pumps that we put on their legs. You can use compression stockings, or really closely look at their skin. That's so important. And then a lot of times we are the ones who are initiating the medical management. You're alerting your provider that is, you're really suspecting that there is a DVT in the making for this patient. So again, just honing in on your observational skills and really paying attention to all of your patient. I know it's 2:30. Kate, I don't know how we're doing. Should we move forward to the case study?
Yeah, that would be great.
Okay. So I will let you guys just kind of breeze through your bladder and bowel function, which is huge. This is a whole conference in itself when it comes to this population, but just hopefully some of these slides will guide you in your thought process as to what you need to start thinking about, and what you could be doing to assist. So I'm just gonna slide through towards our case study. Okay. So the case that we're going to try to discuss and see how we can sort of unfold it, how we can think of clinical reasoning here, is John is our 38-year-old carpenter who sustained an incomplete spinal cord injury following traumatic fall of an extension ladder while installing a treehouse for his 6-year-old twin boys. By the way, this is actual a situation. The names are changed, but that this situation has happened. When he arrived at the hospital, John required 3-level cervical spine stabilization surgery and is now required to wear a hard cervical collar for 3 weeks. And he has cervical spine precautions to go along with it, which means no bending, no lifting, no twisting. If you're not familiar, and you're not raising your arms above 90 degrees of shoulder flexion. Following the initial OT evaluation, the below is evident. So John is depressed and often states, "Why are my legs not working? When am I going to walk?" Such a typical response, right, for spinal cord injury patient. He is right hand dominant. Manual muscle testing reveals that his shoulder elevation is at the strength of 3+ out of 5. He has scapular protraction and retraction of 3+ out of 5. Shoulder flexors, extensors, shoulder flexors are 3+ out of 5. Shoulder abduction, 3+ out of 5. And extension, there is elbow flexion, that's 3- out of 5, right? So he has some biceps. Elbow extension is 0, no wrist flexors or extensors. The digits are non-existent at this point. Sensory, apologize for that, I'm just seeing a typo here. Sensory is intact, light touch, and pinprick proximally from the elbow. Once OT facilitated John in understanding the importance of breaking his goals into smaller components, because you will find your patients, they're just wanting to look at big picture. When am I going to walk? And you are just sort of bringing them down slowly, gently. Okay, this is something that we need to do to start this journey first. Smaller steps, small components. John expressed eventually a wish to be able to self-feed. He wanted to shave and complete his oral care. What do you think is John's suspected level of injury? What is the most optimal position and location to address his goals? So we're thinking here, would you want them in bed, in chair, on edge of bed? Just think about along those lines, how you feel this patient would be Sitting, what would be that in a suspected sitting balance, trunk control? What kind of adaptations can we use with John? How can we anticipate John to transfer from surface to surface? How is he going to get out of bed to the wheelchair or to the commode? And what would be the caregiver's role based on the level of suspected injury that you think John has sustained?
Okay, great. Thank you, Anya. And now Kelsey is going to put everyone in breakout rooms, but if you could, as a reminder, please keep your camera on and your facilitator will join and help with the discussion. Thanks, everyone.
Okay, is everybody pretty much back? I can't see on my portion, but so now we're going to go back in, thanks Kate, to the case study. We're going to go through each question and then we'll kind of break it up by groups. So the first one is, what is John's suspected level of injury? We'll start with Antonis. Did your group have a suspected level of injury?
Hello, everybody. Yes, our group says it's a cervical injury, maybe position number 5.
Excellent answer.
Very nice.
Why did you think that?
Because of the level of the upper extremity um, functionality.
Yes. The key here, right? He did not have wrist extensors yet that we would be expecting to see at C6 level. So absolutely, you're right. It is a C5 level of injury. And moving on to the question of what is the most optimal position and location to address these goals?
Does Tolo's group have anything?
I'm sorry?
Oh, I was just asking the next group, the facilitator, if they had anything for that specific question. If not, Claudia, did your group?
Yes, we did. Our group thought that optimal positioning would be either supported upright in bed, or he could be in his wheelchair, or possibly a chair with arms on it, an armchair, and something that's going to give him that good back support. 90 degrees is positioning at the hips, and to address his goals. So either wheelchair, armchair, or supported up in bed in all 3 of these cases at 90 degrees hip flexion.
Claudia, so yes, very good point. Definitely supported sitting. This person is not going to have enough trunk control. But as far as the 90-degree hip flexion, you probably would need a little bit more, because they will not be able to sit at 90 degrees, right, fully upright, because they may sort of lose their trunk forward. So we would want them slightly more reclined. So I hope you're all seeing me reclining in the chair, but we would just want that trunk supported as much as possible. So just a little bit of, it cannot be straight position, it would need to be slightly back. So there'll be a little bit more than 90 maybe at the hip. But excellent point for absolutely supported sitting, because this individual will not be able to sit on their own.
Okay, nice. So we'll go to the second one. What kind of adaptations can be used? Sarah, did your group have anything?
Yes, you bet. And I'm going to go ahead and pitch to Anna, who, Anna, if you're available to undo your screen. Cool. I'm going to make her big. Let's see if I can make her big just for the second she wants to show you something. Okay, go ahead, Anna.
Here. Oh, can you see it? It's like a sling. It's made out of, yeah, you can make it out of any material if you want to. You just put your hand in it, and then you can, wrong way, then you can put a spoon or something else, any device, into it, like this. Can you see it?
Yes, so that's the example of universal calf. Anna, I can't tell, is it a prefab or did you make that?
I made it. Yes. So we
I
talked,
love it.
yeah, we talked about the fact that we'd have to build something out to help stabilize the wrist since the wrist has no movement. And so, but you know, some type of splint or mobilization device for the wrist, plus this homemade device that Anna made again, just to help again, and that is to help at the adaptation for no hand use or no active movement in the hand at all. So thank you, Anna.
Thank you.
George, did your group get any other adaptations? If not, we can move on to the next one unless Anya has anything else she wants to add.
I would just say that, you know, sometimes if the bicep is not strong enough or there's not enough, you supported the wrist, but they're just missing that mark where they can come close to the mouth. You can actually, in some clinics, you can have arm support, or you can just sort of build up their support. So you're supporting the bicep essentially. You're supporting their shoulder and bicep ability so that they can come to that mouth, because a lot of times they may come short. That's the quick little thing for those three goals for feeding, shaving, or completing oral care.
Very nice. Now we'll go to how can we anticipate John to transfer from surfaces? Meryl, did your group have anything? Just in here.
George is gone, but Meryl is here.
Meryl, did your group have anything for question number 3?
Oh, you're on mute. I'm sorry, Meryl. We can't hear you.
We cannot talk too much about this question in the group.
Okay. Did any other group get one? Just unmute because I cannot see everybody on the screen.
Our group did, if we may.
Go for it.
Please.
Well, we said, excuse me, we're at the third question, right?
Yes.
Okay, so we could use assistive technology like high-tech computers with joystick adaptation, think-handed spoons, environmental modification with control units, splints, robotics, and everything that could help him with ADLs, with using his arms for feeding and help shoulder stability.
That's great. Antonio, you actually went to question number 2. What kind of adaptations can be used in self-feeding? And I'm sorry, it's confusing, I think, because there was a general question: what is John's suspecting level? And then the numbers are going from 1 to 4. So I see where that may have felt like question number 3. We were actually those are fantastic options that you guys, you were very thorough in listing all the options that some great clinics can have. What we are on the next question, where how we can anticipate that John will transfer from surface to surface. So how will he get out of bed to the wheelchair, for example? Is he able to do this on his own? Is there a level of assistance that required? What do we think?
Okay, excuse me. I just got confused.
It's okay.
Well, we talked about hoists and transfer boards.
Yes, definitely initially a Hoyer, because C5 will not have enough trunk control to sit. As they are progressing, they are able some really strong, depending also on that zone of partial preservations, how are the other muscles innervated below the injury. And if it's an incomplete injury, they might be able to use a sliding board, but not likely independently with caregiver's assistance.
And then just for the last one, Anya, in the sake of time, do you mind quickly just going over what a caregiver's role would be? And then we'll wrap up.
So most importantly, in bowel and bladder, which we didn't go into, I know, guys, but these guys will not be able to likely do their hygiene, toileting. A lower body dressing would be partially accomplished, but still would be challenging. So caregiver's role would be hugely important with still those ADLs and IADLs, skin, any kind of skin breakdown, skin inspections, that's where caregiver would come in, particularly during the initial phases, right? During those acute phases, these guys might be able to get to the point where they can do their own skin checks. Again, multiple factors come to play: body habitus, flexibility, joint age, all of those. They're always the variables, but they're still, caregiver would be largely involved in the life of a C5 patient. Are there any other questions? I think we're running out of time anyway.
Well, thank you so much, everyone, for joining OT Echo today. Anyone can email me with follow-up questions, and I can forward them to you, Ania. But this was really great. I appreciate it, and we'll post this on the website within the week, and we'll see you all next month. Thank you, everyone.
Thanks, everyone.